Welcome everyone. We're very excited about this session this morning. We have three great guests that are going to lead us through the discussion. So before we get started and explain things, I would ask that you do stay muted during this session until the question and answer period. We are recording this session and we'll make it available to everyone who's here. And so before we start, I'd like to just start with our land acknowledgement. While we may be connecting virtually, we would like to acknowledge that Hospice of Waterloo region is based on the ancestral and traditional territories of the Anishinaabe, the Haudenosaunee, and the Ottawandaron neutral people. Today, this gathering place is home to many First Nations, Métis, and Inuit peoples, and acknowledging them reminds us of our important connection to this land where we live, learn, and work. As citizens, we have a responsibility for the stewardship of this land, and I invite you to join in consideration of our collective role in the stewardship of Mother Earth and in the important process of reconciliation. Again, thank you for being here this morning. We have with us this morning three great guests. We have Ann Bettles from the Community Paramedic team. We have Elaine Shantz from Fairview Mennonite Communities. Is that correct, Ann? Elaine, I think I got that wrong.
Fairview Parkwood Communities.
Fairview Parkwood Communities. And then our own Adrienne Barker who's the Director of Care of Hospice Waterloo Region's residents, the Cook family residents. I'm not going to go into their bios because I did send them out to everyone, and I have asked that during the session they can share a little bit more about themselves as they talk. The way we have it structured today is we're going to start with our three by asking three different questions that will give them time to answer. So about 15 minutes each for each of the three questions, just to give you a taste of all the expertise and experience in the room. And then we have left a fair amount of time for question and answer so that you can direct your questions to them. With us this morning, we also have our amazing ACP ambassador team. Ladies, put your hands up. Just so you know who they are, and they are going to keep an eye on the chat, so you can put your questions in the chat as we go along, and they will bring those forward during the question and answer period. Or you can wait and just put your hand up, or use the emoji that's in the bottom of or in the menu bar, and they'll keep track of that. We will do the chat questions first, and then we will look to you for any additional questions that you have. I think that's pretty much everything that I wanted to cover at first. So you can unmute once we get to the question and answer period. So to begin, we're going to get started, and I'm going to start with the panel, and I'm going to ask Ann to speak first, and she's going to give us a little bit about herself, but also about how advanced care planning has value in the kind of work that you do.
Well, good morning, everyone. My name is Adrienne Bettles. I am with Paramedic Services of Region of Waterloo. I have worked as a frontline paramedic, responding to calls for 18 years. The past 3 years, though, I have worked in a new role of community paramedicine. So that sees a number of our paramedics visiting clients in the community, in their home, on a non-emergency basis to provide support. This role is also expanding this fall to include palliative support in the home. So this is an exciting venture for our paramedics as well, gaining education and experience, helping clients and families who have chronic or long-standing needs. Capacity and planning. I think when most people think of emergency services and paramedics, it's often thought of as a end of life rather than a palliative piece, but that care planning piece comes into role in our job often in the form of a DNR, or do not resuscitate order. And I think that's what individuals are most familiar with. So there was change to this in 2008. Before that, if paramedics were called to a home or after 2008, there was a standardized form that was created, and it was a confirmation form that clients could keep in their house, but it was understood that this had been taken on with some professional. So whether that was a nurse, an RPN, a family physician, they had spoke to the client and their family to determine their needs and their wishes, should they not be able to speak for themselves. So typically when our crews arrive at a scene, they look for that form, and that can be presented by a substitute decision maker, a family member, or some clients, if they live on their own, will have those clearly displayed in their home with their medications or in an easy to find location. On that form, there's a individual code, the name of the client, and there are 2 check boxes. So they often just have confirmed with their family physician that they have a care plan in place that deems that things such as CPR or defibrillation are not in their wish plan. So the benefit of this form is that paramedics don't have to have privy or see that whole care plan. They don't need the legal document that may have been discussed with a lawyer or physician during that caremaking process. This form, if completed correctly and accurately, allows them to honor the wishes of the patient in the home. So that is definitely a positive. Now, to go off of that, there's new legislation in the province regarding palliative care. And paramedics are now being included in this palliative piece. So the next year we anticipate quite a lot of training. But what it's looking at is that if clients are either expected a death in the home, their end of life, or they have an end stage illness that, expected 3 to 5 years of just that need for medical attention at times, but they don't wish transport to the hospital. So this is to maintain comfort, to assist managing pain. That paramedics are now able to go to the home if clients are enrolled in this program. They can provide that treatment and remain on scene to make sure and follow through that it has been successful, and make contact with the palliative team, the care partners, and the family or substitute decision makers until there's been a resolution or improvement, and they can leave that client at home. We know that transporting individuals to hospitals when it's not their wishes, or it's just, they're in such a vulnerable state often when they're distressed, or calling EMS to take them out of their place of comfort. Often long offload delays in the hospital are also something that are unsettling and not nice for families. So we're looking to divert from that and really support them and honor their wishes in that way. And it will allow us to work with the palliative teams as well to have a more focused care plan and be able to contribute as a community.
Thanks, Ann. Elaine, do you want to talk about long-term care in congregate settings with your expert opinion?
Just get myself off mute.
Okay.
It's great to be here today. My name is Elaine Shantz, and I am, as Shelley said, from Fairview Parkwood Communities in Waterloo and Cambridge, and really appreciate being part of this discussion. So our campuses of care do have seniors active living centers. So seniors and older adults coming from the community can come to our campuses every day for therapy, swimming, fitness, meals if they so choose. And then as we think about that campus and expanding, often in independent living and affordable housing apartments as well. And that's where we interact a fair bit with Ann's team as well, and some of the directives that she was talking about. We do have retirement and long-term care as well. And in the past few years, we've been identified as a service provider organization to provide home and community care services with our team beyond our campuses. So in my role as CEO, I have the opportunity and the privilege really to be part of all aspects of campus life. I will also mention that I am a daughter. I am a substitute decision maker for my mother. And I do have a power of attorney for her personal care and also another one for her financial care. And today my mother is in long-term care and she's 99 and she's been there actually for 8 years. So starting with my perspective as a leader in congregate settings for older adults And as well from my personal experience in response to the question as to how and why advanced care planning is important. When an older adult is entering a congregate living setting, wherever it is, whether it's retirement, whether it's long-term care, and perhaps even those independent living apartments, it's usually due to an event. Perhaps it's a spouse or a caregiver who has passed away. Perhaps it's a change in health status. Perhaps it's for feelings of isolation. Or it could be that the person has been, the individual has been at home. And especially during COVID, we've seen a lot of this, living in their own home and perhaps with declining health status, and then makes that move into a congregate setting. And one example that I always think about is a gentleman by the name of Bill. And Bill and his wife, Bill had some physical disabilities, and he and his wife lived in Arizona during the winter. And his wife was the caregiver. She passed away suddenly. And within 2 weeks of his wife's death, Bill moved into one of our campuses. And you know, my heart just broke for Bill. He was not only grieving, he was adjusting to a new home. He had come back from the sunny south, and his life had changed significantly. It was an incredibly emotional time. And that's not unusual. For the older adult, it's an emotional time. For their family, it's an emotional time. And sometimes it can be a confusing experience. And at that time, when moving from home where someone has lived for perhaps many years, and they're striving to make a new home, is not the time to start the advanced care planning. It's not the time to start thinking about it. It's important to have had that happen prior to this event that is changing someone's living status. And so it's not the conversation when someone moves into our campus that we want to have on moving day. And yet there's a need to clearly understand what the wishes are of the person that's moving to our campus. And I have to say, just as an aside, it's conversations like the ones we're having today that have really been successful, because this has really shifted in the past few years, that people who are moving into our campuses have given this thought and have made decisions ahead of time. So incredibly important that it's done ahead of time. It gives peace of mind to the older adult that they know who their substitute decision maker is, what their plans are, and it also gives clear direction to the long-term care or the retirement home team. And so we can, right from day one, we can respect the individual's wishes. We get to know you a little bit better through those wishes. So one of the things that we like to see and we feel is really important from a congregate living setting perspective is that perhaps there is a power of attorney for personal care. There is a substitute decision maker who's been appointed. There may be a power of attorney for finance. And that also beyond that advanced care planning has been done. And it might be the same person as it is for me with my mom, but it might be, and that's worth conversation as well. There might be more than one substitute decision maker, but incredibly important to think about this ahead of time and to have those decisions in place, because it just makes life so much easier. And I'll pause there, Shelley.
That's great. Between you and Ann, I think we should carry you around with us in the public, because you guys speak so well. So not to put any pressure on you, Adrienne, if you could just share a little bit about yourself and about all the great work you're doing at Hospice.
Sure. My name's Adrienne Barker. I'm the Director of Care at Hospice of Waterloo Region. I'm also a nurse practitioner, and for a number of years, I was doing community palliative care, so home care for folks who are at end of life or approaching end of life. So that could be anybody who I have received a referral from. Here at Hospice, a substitute decision maker, it's important to know who they are because they will be asked to speak on behalf of their loved one if they are no longer able to speak for themselves. And so we do rely on them to help make decisions at end of life, particularly around treatment plans, pain medications, sedation, and also how someone might leave the building once they've died. So what would that procession look like? Would they want a procession? What's important to them? So the substitute decision makers are often called on to be the voice of their loved one while they're here. Anybody entering hospice, we do require a do not resuscitate order. It's one of those things where we are not the facility that is going to perform CPR on anybody who is admitted to our facility. And I want to make that clear. If you come in and you're a substitute decision maker, we're probably going to do CPR on you, but not our patients that are in our care. We work really, really hard to ease the decision-making process for our residents and their families. And I would see this as a nurse practitioner too, when I would go into the home. One of the big discussions that I would have with family members is, well, I don't feel comfortable making decisions for my loved one or this person in particular who I've agreed to care for. And what I found very helpful was to discuss that substitute decision maker isn't making your decision for the person that you're caring for. It's making known the decisions that they've already made for themselves. And so often I would go into the home and along with some of my colleagues and have what we would call goals of care discussions. And those really establish what the substitute decision maker should be doing on behalf of that individual if they can't speak for themselves, or if they're having an event that is unexpected. So that can be anything from some of the legacy work that we do. How would you like end of life to proceed? What is important to you at end of life? As well as what kind of treatments would you want initiated as you're approaching end of life? And that changes. So it's an evolution, but the goal that we have with those conversations is to alleviate the anxiety and the fear that a lot of folks have with substitute decision making. You're not making the decision for your loved one. They've already told you what they want, and that's why we try and discuss it early. So that continues once folks are admitted into hospice as well. What's important to your loved one? How do we provide the best care for them? Who are they? What's important to them, and how do we maintain that dignity and respect at end of life? And again, reinforcing that any decision that you're making really is the decision based on discussions you've had with your loved one. They're not always easy discussions, and it can be quite a process. And that's what I found working in community is it's multiple conversations over a period of time to really figure out what's important to that person and to put someone's mind at ease. And generally, once folks grasp that concept that it's about the needs of the loved one and their decisions prior to incapacity, that puts them at ease. And suddenly they feel comfortable saying, okay, I understand what, mom or dad or grandma, grandpa, uncle, aunt, friend, would want, and so I feel comfortable doing that. And that also highlights if I were having those conversations with someone in the home and they weren't comfortable making those decisions on behalf of someone, then we would have a discussion about, well, who is comfortable doing that for you? If you don't feel comfortable doing that, then we need to find someone who is, because it's about the person. It's not about your fears and your wants and your needs for your parent or loved one. or the person that you're making decisions for. It's really about what they want. And so if you can't make that decision for them, you need to step back. And so we would have very delicate and gentle conversations around that, because that's a really hard thing for people to work through. Once you come to hospice, though, we really do our best to walk with people and explain what end of life looks like. And so taking away some of that fear and stigma around death. And more broadly, we just try and support the families through that process. We really walk with folks as they're having those discussions, and that starts from diagnosis all the way through to dying breath. I'm going to stop there.
Okay, so I got to carry you around in my back pocket as well, Adrienne. That was very good. Thank you for that. So my next question, and I'll come back to Ann, is in your role, what would be expected of the substitute decision maker? And again, what would that role look like from your perspective? Any challenges or stories you'd like to share? We'd love to hear them.
I think for paramedics, one of the challenges for substitute decision makers, I think, is that we are often on the other end of the spectrum from Elaine and Adrienne. We're often at that starting point. I like how Elaine mentioned there's often an event, a trigger that might transition someone to long-term care or assisted living. For us, often that event can be that call to 911. There's been a change, there's been a concern, and we've been called. And oftentimes, because it's maybe the start of a process or an unknown journey, there might not be a decision maker in place. So more often than not, I've arrived at a scene and there isn't an answer for that. There's a spouse who might be supportive. There could be children on scene who are aware of their parents' medical conditions, physicians, specialists, medications, but there often is not a formal discussion that has happened. So in some ways, I look at it as a privilege to be part of that, because we can ask those questions. Has there been a discussion? Have you talked? And usually we also have that benefit of speaking with the family. We work in teams. So usually one of us will go tend to the patient, one will tend to family members or support. And usually it's the same theme I hear. We talk to the patient, and if the conversation hasn't been had, it's, I don't want to burden them. I don't know if I'm ready to talk about that. And if we talk to either the support system or the family, they're like, well, I don't want to talk about it if they're not comfortable. And often you'll find both parties are wanting to discuss. It's right there. They want that planning together, but it's that getting over that uncomfortable barrier. And sometimes I find that we can be that connect, which is, it's a positive thing. And it's something that in this job, as I thought back over this presentation, I've been fortunate to be a part of. And even with people who haven't had those conversations, to be able to say, reassure them, everything looks fine now, or you're stable, but have you thought about this? What would you be interested in moving forward? Have you discussed this? Do you have somebody you trust? And I think we are able to plant that seed if it hasn't started. And get those conversations rolling. And that's one positive. We often hear in the media, the negatives about long hospital waits, offload delays. They're not something we like to see, but a positive that has come from that, I think, is that paramedics are able to spend longer with their clients and have those meaningful conversations and try to help start the process and navigate those items with families. I've seen situations where there has been a substitute decision maker in place. And I think the discussions, like Elaine mentioned, that they're so key that it makes things go smoothly. The pre-planning is so essential. When we go in and there's a family member or that support system who can tell you when you arrive, I'm the substitute decision maker. They're usually able to tell you, I have the paperwork, I have some medications, here's something I'd like to tell you about the patient or our client. They're really able to provide that scope. And you can tell when there's been some conversations, there's a comfort there and a little bit of a confidence, because much like Adrienne said, it's not that they're carrying out their wishes. They're putting forth those goals of care and what the client wants, right? They've had those conversations. It's a little more unorganized when there haven't been discussions, right? And sometimes it comes down to that deciding factor. I feel comfortable with my spouse perhaps, or maybe there can be a disagreement in their beliefs, but they've confided in a child. But when those conversations are opened up, definitely it streamlines the care and makes that delivery of services much more clear, and gives us a confidence too that we're supporting the needs and the wishes of the clients, certainly in the community. Oh, Shelley, you're on mute.
Probably wasn't worth it. I'm just going to say the emphasis on the pre-planning and how that changes how the care is delivered is so big. I also really liked what you said, Adrienne, about reminding people that if they're uncomfortable, that it's not about you having to make a decision, it's about you being the voice of the patient or the client's decisions. That's excellent. So on that note, I'm going to turn it over to Elaine.
And maybe just one comment on that, a thought that it has sparked for me as well, recognizing, in my previous comments, I said it's important to have these decisions made before you move into a congregate living setting. It doesn't mean, though, that those decisions can't be changed. Your wishes can be changed. And as long as you have capacity to change them, if you are moving into a long-term care or retirement home, those decisions are reviewed every year. And when you have a care conference, they can be changed at any time if someone chooses to be able to do that. And as well, a substitute decision maker does get involved in that in the event that a resident doesn't have capacity. So some decisions can be changed at a later date. It's an ongoing conversation. So what's expected of a substitute decision maker in our setting, and we've touched on this already. The short answer is the substitute decision maker makes decisions when you or when the resident cannot, when that resident no longer has capacity to make the decisions. And that's not always clear cut. For example, I may not have capacity to make financial decisions, but I still have capacity to make other decisions in all other aspects of my life. This may change, and sometimes even for our residents, it can change on a day-to-day basis, depending on what the decision is. And so really important for a substitute decision maker to understand and to recognize that. And perhaps one of the biggest challenges that we sometimes have as the healthcare provider is the substitute decision maker just wants to make the decisions, and not necessarily intentionally, but kind of gets on a roll in making those decisions. And so it's really important to recognize that in our case, especially in long-term care, a resident's world gets incredibly small. It gets smaller and smaller. And as it gets smaller, the decisions that the person is able to make and the choices that they wish to make are, it's so important to be able to maintain that independence just as long as possible. And so it is often the healthcare professional's responsibility to determine if the resident in our care has the capacity on any given day to make the decision for themselves. And I would just refer to, and I think when I was part of this group last year, I might have used this example. So bear with me, but it was so impactful for me. We had at one of our campuses, and this is a number of years ago, a resident who was nearing end of life. And the daughter was a substitute decision maker for her mom. And the daughter did not want her brother to visit our resident. The brother desperately wanted to see his mom. He was also a substitute decision maker. So all of a sudden, this is a difficult situation. who makes the decision. And Mom, the resident, was capable to make the decision. She wasn't making very many decisions in her life. I'm sure she wasn't making financial decisions at that point, perhaps not even decisions about medication, but she had the capacity to say, I do not wish to see my son. And so that was her decision. It was clearly her decision. However, at the end of life, she lost the capacity to make that decision. And the son, as a substitute decision maker, determined that he could come in and see his mom. As a home, we really strive to remain neutral. We strive not to get involved in family situations because they can be very challenging. And, you know, it really broke my heart because as I looked on in that situation, Mom's wishes were not to see her son. And so, but the son, as a substitute decision maker, was able to make that decision to come in. And it really had, I share that example because it had such a lasting impression on me that it is incredibly important to choose the right substitute decision maker, the person who really identifies with your wishes and understands them. Because it's really hard to think of every eventuality, every decision that might need to be made. And so important to choose the right substitute decision maker, to perhaps not simply say, I have 3 children, they're all going to be substitute decision makers. That's often the most difficult challenge that we have, because if the family doesn't agree, they try to, and it's an emotional time. And so everyone's own thoughts and own values come forward. And so it's very difficult. So when choosing, it's important to choose the right substitute decision maker who identifies with your wishes. And then, as we're going to talk about a little bit further and have touched on already, having those wishes written down. And so that when end of life come, as Adrienne has already so well spoken to, everyone knows what those wishes are.
I'm smiling because I can see my ACP team, the hundreds of presentations that this group has done, and you're nailing it for them. And I'm thinking that 2 of them who are presenting this afternoon are probably scribbling notes to add to what they already have. Anyway, on that point, I will, Adrienne, turn it over to you.
Thank you. So I'm going to speak to 2 settings. I'll speak to my role in community briefly. And so one of the conversations I would have as a nurse practitioner, often I'd be coming in at a very tenuous time for people. They've received a diagnosis that their illness is terminal, and they've been bombarded with information. So one of the things I would do as a nurse practitioner going into homes is find out what exactly they understand about their condition and where exactly they're at in planning and understanding how this disease may play out. And so with those conversations, lots of things would come up. I mentioned goals of care earlier. Talking to your loved ones would definitely come up, and often they would be included in those conversations. But also the DNRC, and I know Ann spoke about this a little bit earlier, and speaking to people about what that represents. What I would find with the individuals I was caring for is that do not resuscitate form becomes an albatross in some ways. It represents death. It represents the end, finality, and for a lot of people, a loss of hope. That if they sign that, or if they agree to have that form signed, that there's no hope left for them. So one of the conversations I would have with people is that this isn't a final document. This is a document that describes what you want and what your hopes are should you not, should you be found in a position where you're unconscious or you need CPR done. And I would couch it in terms of, I would frame it with the idea of what CPR would represent for them in that moment, given their current state and whether it makes sense. Because I think a lot of people find that palliative care and end of life is really about do not resuscitate, and it's not. And so we would have conversations about what exactly is that form for. And I would also make sure to let people know that it's not stone. It's malleable. It's something that changes. So if somebody is still undergoing treatment, because I would see folks that were maybe still having dialysis or waiting for a kidney transplant or undergoing chemotherapy, but things haven't been going all that well, or they've been told that they're likely approaching end of life, I would say it's what makes sense for you. I can give you the facts and figures of what that might represent, and what the outcome may be, but ultimately it's your decision. And so that form, suddenly the pressure would be taken off with that form, and we may or may not sign it in that particular moment. But it's always coming back to that idea of what does this represent for you, and what do you expect for your life? What would you want for yourself at that point? For the substitute decision makers, they were often involved in those conversations, and so all they really had to do was listen. And I would do my best to try and have someone present if we knew that we're going to have those conversations and it was going to be either a challenging conversation, or one where it hasn't been brought up before. Because again, these are heavy conversations. You're talking about your hopes, your wishes, but also where you're at in a very real context. So there is a bit of good news, bad news delivery there, because you really get to understand who you are and where you are. But at the same time, you're talking about, what your end of life might look like. So we always do our best to have those individuals present, the substitute decision makers, when we're having those conversations, because if they're just listening, then they get to understand what that person wants for their future. When someone comes into hospice, that substitute decision maker helps us understand who that individual might be. And so one of the things we do here as a team is it starts from intake. So I do the intake assessments for our residents coming in. I ask, often it's a substitute decision maker because we can't talk to families very easily when they're admitted to hospital. And I would say about 90% of our folks come from hospital when they're admitted to our facility. So I ask folks, what do I need to understand about your loved one so that we can make this place a home for them? And that gets the conversation started. And I'm learning too, to actually lead with that. So that used to be one of the last questions I asked when I was doing an intake assessment. It's become one of the first, because then when I start to introduce legacy and do we need to do legacy work with your loved one, so that framing it in terms of that instead of goals of care is this very strange term that we use to say, what do you want for the rest of your life? What's important to you? What do we need to do to help you die well? Make you feel more comfortable and make sure that your loved ones are supported. We call it goals of care, but really it's what's important to you. So I start that conversation right off the hop there. When folks arrive, the staff that work here, either our intake care coordinator or the RNs and the RPNs who work here, will sit down with the family and we complete a document called Life Through My Eyes. And really that goes from everything from food likes to music to how I'd want care to be provided. There is a belief that once you hit hospice, we stop all treatments. We don't. We're a different type of hospice in that we really try to admit people earlier in than at true end of life, like we're looking for folks that maybe have a prognosis of about a month or so, if not a little bit more, so that we can do some of that work. And so what that means for us is we're having conversations about, would you want antibiotics? We probably give more antibiotics here than a lot of places would, simply because if somebody has a urinary tract infection, but they're doing well otherwise, it would make sense to treat that. So those are the conversations that would be expected of both the resident and the substitute decision maker. If their loved one develops delirium where they lack capacity to make those decisions, and that's an acute illness, and we need to make a decision about to treat or not to treat, and we have a strong suspicion that it's related to an infection, and we knew beforehand that the person would want that infection treated, we're still probably going to treat it. But it's a discussion with everybody to say, well, what's in the best interest of this person and what can we expect? In our case, we're not looking for a profound recovery. We're looking for, maybe a week or two more of time with a loved one to complete those legacy activities. That's important to them to reach the goals of care. And so that's something that we would look to the substitute decision maker to do. At end of life, when somebody can't speak, it really is about, the medications that we might choose for an individual. Would your loved one want this? So we still have a lot of conversations about treatment and goals of care once they're admitted to hospice. And again, we do our best to try and figure out what that represents for the individual right off the hop. And it's an evolution. So what might be true at the beginning of someone's admission may not be true at the end of it. And so we really do our best to honor that.
Doing that. That's excellent, Adrienne. I came across the statement, and I always have it in the back of my mind, which is you just pretty much said, what do I need to know about you as a substitute decision maker, not necessarily a medical person, but what do I as your SDM need to know about you to make sure that you get the care that you want at whatever point that has to happen. So I like that you reinforce that and then put it into the context of hospice. Thank you for that.
We do a lot of ice cream here. And that was one of the things that my kitchen supervisor was really worried about when we first started up was, how do we get enough ice cream? Everybody wants ice cream, because that was one of the first things that people responded to was food. I want to eat this. And they've been told, we would have folks with diabetes who would say, all I really want is a piece of pie. And so, do you want an a la mode? Like, here's some ice cream to go with it. Because it's about what you want. And more often than not, when folks are coming in, if they have that opportunity to make those decisions for themselves, we'll give it to them, because they've been told by medical people and folks like myself that, eating a piece of pie with a bit of ice cream is probably going to kill them. And so they should avoid it. And they've been avoiding it for years. The number of people I meet who, really adhere to those things that they've been told with respect to food is amazing. I'm not one of those people, so I don't identify with that, but that we really do our best to do that. So it's silly, but it's one of those things. Ice cream. If you want ice cream, we're going to give it to you. Yeah.
Okay. On that note, if you take nothing else away, take away the importance of ice cream. Okay, so last question before we go into the question and answer period. So if you do have questions, you can start putting them in the chat, or you can wait for the opportunity just to raise your hand if that's easier. So last question, and you guys, the three of you have probably covered some of this already, and your answers have been amazing. I can tell everybody's listening, which you emphasized, Adrienne, we should be listening. So I can see that that's happening here. So last question, what should a person, based on what you've seen, the three of you have seen, and I'll start with Ann again, what should they be talking about? What should be in these conversations to ensure that SDM knows what they need to know to be able to ensure the person gets the care that they want? Ann, I'll start with you.
Yeah, I definitely think the listening and respect, knowing that you've got the trust in the individual you've chosen, is excellent. I want to tie that question into what Adrienne mentioned, though, about the DNRC, about it being a working document. So definitely your decision maker, when you have those conversations, that completion is your decision at the time. Even if that has been completed, though, we want to honor the most current wishes of our client. And I can think of two examples that I've experienced personally that have really brought that to light. One, we were called to the residence, and the gentleman was nearing end of life. It was very imminent, and his spouse was there, and she was substitute decision maker, power of attorney over finances and wellness and health. And they'd had these discussions. They were prepared. DNR was in place, medications, very articulate, both of them. And he expressed to our crews, was able to communicate right to, please help me. And it's like, well, what do you mean by that? He goes, do everything to save me. I'm not ready to go yet. And those are those powerful moments when that's when your judgment comes in. You look at his wife. At that time, we are not going to honor that DNR. His most current wish is that he wanted those interventions. And that's a great thing, is that it can change. It is flexible, because I think, like Adrienne said, there is that sense of finality. If that signature is obtained, that document is complete. And I like how Elaine said that it's revisited every year to make sure that the most current care plans are in place. And another call that comes to mind as well is one where the family had arrived at scene at the residence, and the client was nonverbal, and they are in place. We've been talking about this, it hadn't happened yet, but there was a very grave diagnosis, poor prognosis. This client wasn't expected to have very long. And our team was able to call our base hospital. So we work under a physician as paramedics, and we have access to a phone line throughout our shifts. We immediately receive connection. There's always a doctor with that phone, and we can explain the situation, because every situation is unique and there are so many variables that come into play. And when we can paint a picture for that doctor, tell them what's happening, what is going on, how the situation has changed, and what the current treatment plan is, oftentimes they can grant us a directive or give us an order number that we can follow. That might also come into play if we arrive at scene and the family member's not there, but they tell us there's a DNR and it makes sense with what we're seeing. So that's a heavy piece too. But as Adrienne said, those are the conversations that need to happen with the substitute decision makers. How, maybe play out a few scenarios. I find that happens. What would you do if I change my mind? How do you feel about my decision? And I think those conversations and having questions on both sides help to determine if the person, presumably, I noticed before how you said about, I have 3 children. I think that's so common. I have 3 children. They're all going to have an equal stake. But we know that there's some people who say, I just know I'm those conversations are so important, because in our role, the substitute decision maker is often speaking on behalf. So it's a knowledge of that change in care. And they're often, if EMS is called, it's usually at a critical point, and it's not easy. Either there's been a change in condition, or it's for direction. Sometimes the death has happened, it's expected. And if that paperwork is presented to us, it's a navigation point. What do I do next? Because that sort of legacy piece hasn't been discussed, or how we're going to make our way to the next destination. Be that, funeral home preparations, be that victim services. Often those are sort of the angles that EMS is directly involved with. And at that point, often you're supporting the client, but you're moving into that segue supporting the family as well. So I think the communication piece is huge in the pre-emergent part of our job.
Excellent, Anne. I hadn't really thought about playing out options if with EMS coming to the door, and what if you changed them? And that's an excellent point. Thanks for sharing.
And I think so often there can be a clear plan in place, but none of us know what to expect at that moment. And, it can be overwhelming. And often we get a call and it's overwhelming. And it's just even the paramedics having time to sit with the family, provide reassurance and play out those situations. Sometimes that's all that's needed. And it's just that extra ear to listen and give some guidance. Absolutely.
Mm-hmm. And you mentioned before about kind of being that connector for those conversations that haven't taken place. So that, I'm assuming, would also play into your community role and with the client base that you have that you're working with that are at home, not just the
Absolutely.
emergencies. Yeah.
Mm-hmm.
Okay. Thanks, Anne. Elaine.
Sure. And speaking of ice cream, Adrienne, I love that comment. It reminded me of a gentleman that lived in a retirement home where I was at the time the general manager of, and he was having dialysis for a long period of time and made the decision to discontinue his dialysis. And as we honored his wishes as his end of life neared, and his desire was to have a beer. And he said, I have not had beer since I have had dialysis. I am going to have a beer. And he did, which was great. And then what was really neat to see is one of the team members, as he neared end of life, made ice chips out of beer. And they continued to respond to his wishes. But, you know, it was just a nice moment of care. So the ice cream brought that back for me. When I think about including what to include in those conversations, perhaps I'll talk a little bit about comfort measures. And I mentioned my mom, and I'm going to talk about that from the perspective of being the daughter and thinking about decisions as a substitute decision maker. And then I'll also give you an example of a resident. And perhaps for me, giving some examples is the best way to describe the conversations that are important to have, and sometimes the ones you wish you would have had as someone nears end of life. My mom's condition today is not one she would have ever imagined. She's nonverbal, and very few days do I even have eye contact with her. And so making decisions right now, we are making decisions for comfort measures only. And what does that mean? What does that really mean as I make those decisions? It's a decision, was a decision. Should she be vaccinated? Should she have the COVID vaccination? Should she have the flu shot every year? What about antibiotics? And, you know, right now, if she should get pneumonia. So what do those decisions mean? And as we think about comfort measures and as she nears end of life, those are decisions the substitute decision maker needs to make. And Adrienne, you mentioned about antibiotics. That's something I may change my decision on in any given moment, depending on her conditions and depending on why she might need antibiotics. But every once in a while, I go back to her handwritten document that says, do not give me anything that will extend my life at the time when I no longer have quality of life. And seeing that in her handwriting and knowing we had that discussion and made that decision, that I clearly understand what her wishes are. And so, you know, this year, a decision I made for her, which we didn't talk about, when I had her care conference, you every year have to sign off. Are you willing to let someone have their picture taken to be part of activities of the campus? And I've always said yes to that because we do it in our homes, and it wasn't something I really thought about until this year. I decided she wouldn't want her picture anywhere other than if it's identification for medication on a med card. And so I said no to that. So those are decisions that come along that a substitute decision maker needs to make. And it's really important that whoever you're a substitute decision maker for, that you know what the wishes are, so you can start and really try and think like the individual that you're making decisions for. A resident example I will give you, this was in long-term care, a resident who was being fed through tube feeding. It was the resident's decision at the time when that took place. However, the resident no longer had capacity, and the 3 children were substitute decision makers. And so when does that treatment stop? And the substitute decision makers didn't all agree. Fortunately, over time, they came to an understanding together, but we did actually suggest to the substitute decision makers that we take it to our ethics board and have the conversation there to get an objective opinion from a bioethicist, from a physician who was not involved in care, and that they felt as a family they would respect that decision. So when you start to think about comfort measures, there are many decisions, especially when you get to long-term care. And generally, I will say most of our residents definitely do not resuscitate, but there's so much more than that. There's those comfort measures, and what does that mean, and how does that change? And then as well, the conversations to have with a substitute decision maker, and Adrienne and Ann have spoken to this. What about after death? What are those wishes? Or just prior to death, who do you want at your side? What are those things that you wish to have after death? And, you know, again, I have these little, my mom has lived long enough that none of her friends are living. And I've got how many bulletins where she's written on, I like this hymn. This was a really nice scripture. And taking those things and thinking about what her wishes would be makes it much easier as the decision maker. And finally, a little bit off topic, but if you agree to be a substitute decision maker, recognize it's an important role. It takes time and it takes strength. And if it's a family where there's others involved and they might not be the substitute decision makers, really have good communication with your family as well. What is the health status of your loved one? You know, even financial, what does that mean? Honesty and transparency and sharing information really helps as you do near end of life.
Thank you for including that, Elaine. That was excellent. That's an excellent point. I'm not sure. So I've got ice cream. I've got ice chips. I know there's more here than that. I appreciated your comments about the handwritten notes, and I know that while it's not mandatory in Canada or in Ontario that you have to write your wishes down, we've heard over and over again and seen it that it brings such peace to the individual, the person who's a substitute decision maker, to have that written down. So whether it's written or it's in a video or a recording, whatever it is, we do encourage people to consider that as a way for someone to have that guidance, because we can all forget things over time. So I appreciate that. All right, Adrienne, your turn. Last but not least, for sure. You've made some amazing points this morning.
Thank you. I think what people who I have encountered should be expected has been really discussed well by Ann and Elaine. It really is a comfort with the discomfort of making those decisions on behalf of the person who's requested that you do it, because they're not your wishes, and sometimes they're not what you would want for that individual, but it's what they would want for themselves. And so know that it can be uncomfortable to be in that role. I always encourage people to have those conversations very, very early. And we're working on that, I think, as a society, to say you really need to have these conversations early so people understand when you aren't sick what you want. Because once you reach that point where you can't make those decisions, if you haven't had it, it gets that much more difficult. So, you know, when I was in high school, you know, back in '93, that was a while ago for me anyway. That was one of the conversations that my dad actually had with me about, because there was just really beginning some of those conversations about ACP back in the '90s. And he was a family doc. And so he made a point of telling my sisters and I what he would expect, because he was doing some education around it in the community that I lived in. But, you know, we knew that if something happened to him, he wanted to be able to have the odd Ryan ginger, and he wanted to have apple pie, preferably my mother's apple pie, if she were able to do it still. But those were the conversations that we had. And it really highlighted to me the need to be comfortable with some of those things. You know, I wouldn't want to be intubated. I wouldn't want to have CPR. I understand what that represents. I know that that's going to be a difficult decision for someone to make on my behalf, but I wouldn't want to live my life that way. If there was a possibility of allowing me to have a natural death, that's what I would want. I've had those conversations with my partner. My partner knows that if I'm approaching end of life, we need to get a truck, because I want to drive a truck at least for a couple of weeks. And if I really, you know, if it doesn't look, if my prognosis is poor, I just want to spend time with my family. I don't want to worry about other things. And I also know that if my partner becomes ill, I'm not the one to provide personal care. That's been explained to me very clearly, that, you know, I'm not to be involved, even though I'm a nurse, and that's going to be really difficult for me to do. That's the wish of my loved one, that I not be involved in that type of care. And so if we have to pay out of pocket early on, then we'll do that. But those are the conversations that we've had in our household. And I think the earlier on you have those discussions, the easier it is for those decisions to happen when you really need to make them, because it's not a new conversation. It's not a new topic. It's something that has been discussed. Now, I come from a weird family where we talked about this around the dinner table. That's we did routinely, and that's not usual. I recognize that, but my goal in having these conversations with folks is to really encourage people to do that, because it's the only way to have open and honest conversations about what your expectations are. And for any SDM that comes in here, you know, we're going to walk them through that, and what death looks like, what it might look like in particular for their loved ones, what to expect, and that they're not alone. That's one of the big things that we really try to do here, is that, you know, death is one part of the journey, and the next step is walking alongside people as they grieve. And so that also takes some of the pressure off SDMs as well, when it comes to making decisions that might result in withdrawal of care or death. You know, you're not going to be alone. You're making this decision, but you've got a whole team behind you that are going to stand with you and stand behind you to support you when you need it. So those are some of the conversations that we have to help prepare people and make sure that folks are equipped. And it's multiple conversations. I would hear from folks in community that they had never had conversations with anybody about that. And in some cases that may be true, but I know in a lot of cases, the conversation has been started. Once you start speaking with people, you realize that they have had those conversations. They didn't recall it because they were overwhelmed in the moment. So my job is to reinforce and build on what other people have discussed with individuals at other moments. Yeah.
Excellent point, Adrienne. And just on that point, I think we make it sound like it's a formalized big deal ACP, advanced care planning conversation. And really, you know, it's really talking and listening over time. And as I think the pieces are there, they don't necessarily have to be these formalized conversations that people are having. As Dr. Mannix would say, these are conversations between people who care about each other. So it's about love. So it's about sharing. So I think we tend to think ACP is this heavy duty formalized thing. So thanks for putting that kind of more in a better perspective. The three of you have been amazing. There's so much information here. I don't even know where to start. We have about 25 minutes. I don't think I need to recap. So I'm going to turn it over to the team. I know that there are some questions that have come up in the chat. So if you guys want to bring those forward, and if people want to raise their hands, the team will also keep an eye on that, and we'll draw you in so you can ask your questions of Ann and of Elaine and Adrienne. Who wants to start?
I'll go.
Okay, okay.
Linda's got her hand up though.
Linda, okay, sure. And then we'll take, there's a couple in the chat, so we'll get to those as well. Go ahead. Linda.
Oh,
Is that
maybe not.
you might have met me, Adrienne, did you? I'll read one of the questions from the chat. In your experiences, are the SDM and the loved one who is nearing the end of life typically on the same page? Are they able to make decisions harmoniously? That's a hard no. Have there been many cases where you've seen an SDM be highly resistant or disagree with the wishes of their loved one? Who wants to jump on that answer?
Well, I can say from a pre-emergency or pre-hospital perspective, definitely. But I think I was fortunate enough to sort of be hopefully a calming force before we transported to the hospital. And at that time, the individual, the client was still able and competent to make their decision. It comes into that capacity role, right? Even though there was a substitute decision maker, the children involved had been made powers of attorney for finances, healthcare, those sorts of things, and really wanted to dictate the situation. But it's that listening piece. The client still had capacity and wished to go to hospital, and they were quite able to make that decision. So it's having those conversations, and that's where I think sometimes we have a benefit that there's two of us. So one can sort of attend to the client, reassure them, and then the other one can diffuse the situation a little bit and ask about questions and concerns and explain why we're going to honor the parents' wishes, perhaps, or who that ever the individual may be in that situation. But definitely there's not always an accord amongst family, and sometimes it is lack of communication. Sometimes that comes into, as Elena mentioned, choosing the right person, right? Because there's just that we're not 100% connected or on the right page, and that can change as health status changes as well, or as changes occur.
I'd maybe add to that a little bit, Lynn. Death brings out the best and the worst in us, and we do see that, especially in long-term care. And sometimes I think it is often a case when there's several substitute decision makers or several family members, and perhaps that family isn't a family that interacts or sees each other at the best of times. And then they all come together at end of life. And those can be significant challenges. Emotion comes into play, guilt comes into play. Also thinking about children who come from perhaps from a distance, who haven't been close by for the last few years, while their family member has been in long-term care. And then there are those conflicting values. And so it's really the more that, it's hard. Those are difficult situations to navigate, can be very difficult. And so when our care team has clear direction, it's really helpful. It doesn't cover every eventuality. There can be, there can be differences. And certainly now that we're considering, medical assistance in dying, that comes into play as well. People have different opinions and can change their mind at end of life. So there's so many pieces that the more we have that can be talked about through life, those conversations at the dinner table, wherever they are, in care conferences for our team, if we know what our resident wishes are, then we can help to navigate that. But they can be very challenging times. There's no question.
Adrienne, did you want to add anything to that point?
I think the biggest thing is when there is a disagreement, nobody ends up feeling good if the wishes aren't being honored. That's one of those big areas of moral distress for healthcare workers, when you know that something, and it is for caregivers, informal and formal caregivers, if you know it's really not in the best interest for that person, but the family's not ready for that moment. And that can be anything from resuscitation to all sorts of things, to treatments that they just don't really fit with what you think is best for the person at that time. I was an emerge nurse before I was a nurse practitioner, and it really is distressing when you see someone who you know they probably wouldn't want this if they truly understood what was happening. And if you happen to resuscitate them and get heartbeat back, that was also a very distressing moment too, because you knew the outcome probably wasn't going to be good, and they weren't going to get back to a point where they might actually be able to live the life that they were leading before resuscitation. And so they lead to moral distress. But I think one of the ways that folks get through it is to know that it's a moment in time. And one thing that helped me as a young nurse maturing was that it's a process. It is something that you keep talking to the families about, and everything is just one event in time. And so, you keep having those conversations with people so that they understand what their role is and how best to support it, and recognizing that those individuals need to be met with compassion as well, because they're grieving, and it's anticipatory grief that is likely driving some of the decision making, and they're doing what they think is best because they're so afraid to lose someone that they love. So when there is disagreement, it can be challenging, but you just do your best to move one step at a time and work with those individuals, and know that they will eventually come to a realization. They're just not there yet.
Shelley, there's one other question in the chat. What is the protocol for someone who is nonverbal, who has not written their wishes down or recorded them in some way? And then the second part of the question is, and their SDM is no longer involved. So in each of your settings, what would the protocol be if you had no guidance whatsoever and an SDM obviously not available? Should we start with Ann?
That's a great question. Wow. And we run into that all the time. And I can, I have calls coming back in my head. I'm thinking of this, and I'm thinking of seeing Adrienne as that first face, sort of a relief when I come through the door at St. Mary's Hospital. It's funny how these times take you back, but yeah, if we arrive at a scene and somebody is conscious but nonverbal, if there's been a change in their medical status and we've been called, we would try our best to communicate with them. That can even be yes, no questions. Can you squeeze my hand? Can you blink your eyes? We try to use everything we can. There might not be a substitute decision maker on scene, but if there is somebody that can demonstrate they've had a relationship with this client, they've had a recent involvement, that they are aware of the medical situation or the best wishes, we would try to respect that. Typically, though, if someone can't express what's happening and we know we've been called for a reason, it would result in a transport to the hospital. If someone was, we call it vital signs absent, if they were without a heartbeat, if they were not breathing, and we had no one there to guide us, it's indicative that we start resuscitation. Now, if we're at the home, this wouldn't be started if there was obvious signs, if there was indications that they had passed away quite some time before, that would not be started. We would call our physician. Or if there was signs that, for lack of better terms, there was no possibility that they would be able to be resuscitated. We also, and I think that's the change too coming in EMS, that we're using those external resources. We're contacting our medical oversight because we're trying to provide that level of care that makes sense, that common sense factor, that it's not just, this is my directive, I follow it. We do have rules and protocols to follow, but we also try to act in the best interest of our clients and their families.
Elaine, I'm not sure if in your setting that would work because of what you've said earlier about having a plan in place, but have you had situations where you've been caught with this dilemma?
Yes, it can happen. And one of the documents that were sent out actually refers to the hierarchy that's in place. And we do follow that. We are required to follow that. And there are situations where there have been times when there's a public guardian who's put in place to make those decisions that are necessary. If in fact there isn't a substitute decision maker, and then looking at the hierarchy and thinking about, you know, is there a spouse? Are there children? And you follow that hierarchy. And even from a personal level, my mother had 3 substitute decision makers, and the first was her husband. And then I was the second one, and my sister was the third. And I'm the only substitute decision maker still living. And so it's something that we really think about as a family, because it would then go to my brothers and sisters, which really wouldn't be a good choice in this situation, just given distance. And so we've added to that one of my children in the event that I would be unable to act. So when you have that opportunity, it's important to really think about if the substitute decision maker couldn't act. But then there are many cases, definitely, that where it does happen, where the children come into play, and the children become the substitute decision makers.
Adrienne, does it apply to you at all in this case?
I think we would sort of see similar things to what Elaine was talking about. If most folks would have those bits and pieces figured out before they're coming in, but if they didn't, if we needed it to go to PG&T, so the public guardian and trustee, then we would end up doing that. But generally folks have had that figured out before they come to us. We're new though, so there's time.
There are no other questions shown in the chat. I'm not sure, Shelley, if people might want to ask them themselves now.
I think Bill has one. I can see, I think I saw you put your hand up, Bill. Did you want to ask a question?
Sure, can you hear me?
Yeah.
Yes.
Okay, great. Nice to be here with you this morning. I think, to begin with, and I'll try to be brief, to begin with in one word, it's wow. The quality of the content of the professionals this morning has been very high, and frankly, so high I'm overwhelmed, and any further thoughts or words coming out of my mouth are going to be somewhat meandering, and I'm sorry for that, but you've just given me so much to think about. Probably more observations than really questions, which I think in and of itself shows how significant these questions really are. But basically what I'm saying is that there are so many observations, meaning areas that I have no knowledge about. And so how can I have questions if much of the material is new to me? And I'm sure I express the opinions and the point of view of many, certainly my age. So thank you for that information. I also have, I think, a new appreciation for the combination of both with regard to SMDs, these unique combination of both a judgment based on practicality and wisdom. If you know what I'm getting at, wow. Both are equally important in my opinion. At least that's how I see it now. The examples I really appreciated hearing Elaine and Adrienne. One of the examples that I really appreciated hearing about was the example of the mother and the two family members, one of which was not welcome at her bed. Wow, what a complicated situation that must have been. And that example in and of itself speaks volumes in terms of the importance of this subject. Who would think of that, really? Which is my point. Who would actually think about that? And here we are confronted with the need to think about advanced care planning. And yet that, as an example, just one, would never cross my mind. So the conclusion there, I think, is that, wow, do we have a long way to go to clarify, to explain, to pursue all of these issues to the depth that they require to give us the kind of information that will prepare us for making those very significant decisions with regard to our end of life.
Thanks, Bill. I just want to, there's a question in the chat, I think, Elaine, that might be one that you could answer. I don't know if you could see it. I had a situation in BC. So they're wondering if it's the same in Ontario as it is in BC, that they had to make a decision about living arrangements, but the long-term care home wouldn't take direction from the substitute decision maker without a weeks-long process of referrals to determine dad's capacity to make his own decisions. Is that the same in Ontario?
I can't speak for BC, but what I would speak to in this case is these are sometimes complicated situations, and without knowing all the details on specifics, it's hard to answer that question. But I will go back to the example that Bill was referring to. And first of all, I will say that no, a substitute decision maker can make decisions on the day. Like, that's not a problem. If the person is clearly the substitute decision maker, that's been identified, they can make decisions at any time. However, where it's sometimes, and it almost looks like this question is alluding to capacity, there are times when, and in fact, as I mentioned this example that Bill took us back to, in that particular case, it was longer than, the discussion was longer than the example that I gave, in that we ended up, one of the substitute decision makers said, Mom doesn't have capacity to make the decision. And we had to bring a bioethicist in, we had to bring someone in who could determine, did she have capacity or did she not? So I'm wondering, without the question going, without a week-long process of referrals to determine dad's capacity, there may have been some conflict there that took time to determine whether or not the gentleman had capacity in that situation. So overall, it should, a substitute decision maker, you shouldn't have to wait a week. But if there are some complicating, if the situation is complicated around those decisions, then it could take a week for sure. I'm not sure that's a really good answer. But.
I think you, Adrienne wants to add something. Sorry, go ahead, Adrienne.
And Eileen has a question next, okay?
Yep. Adrienne, you want to respond first?
Yeah, I think what kind of strikes me about the question is capacity can wax and wane. It's something that, and because as healthcare professionals, we are striving to go to the source for decision making before we resort to a substitute decision maker. If I know that somebody has a waxing and waning capacity due to their condition, I may want to ask them that question on multiple occasions to ensure that it's with their, within their wishes. And so that can delay the process. And also, in trying to honor those wishes, my job is to really ensure that that person cannot make that decision for themselves. And so, I'm also a medical assistant and dying assessor. Those are some tricky conversations too, if you think somebody's capacity is up and down. But ultimately it comes down to, you know, if that person is able to make that decision, it's my job to make sure that it's them who's making the decision and not the substitute decision maker. So in my opinion, if there's delays, that's actually probably a good thing, because they're really doing their best to honor the wishes of that person and ensure that they cannot make that decision for themselves. I don't know the situation in particular, but sorry, I've got a fly that's suddenly buzzing around me, but I guess there's flies on me. But that's generally what we try and do is if that person can make the decision themselves, then they need to make that decision. We need to ensure that they're able to. I may not be able to make a decision about whether or not I can pay my bill, but I can maybe make a decision about what my healthcare decisions are. And so I think those are important considerations when talking about capacity. It differs, it changes. It is far from unidirectional, I guess would be the term I would use.
Thank you. So Eileen,
I wanted to make a comment about that do not resuscitate. When from my own experience, so it's kind of a question and a statement at the same time. So at the time that my spouse needed to have that in writing, it was registered, right? Because we had to fill out the form in front of a physician. So but his idea of do not resuscitate, and it came up today, but I'm just pulling it out as a highlight, was do not resuscitate me in any heroic measures. So no CPR and defibrillation or whatever. But in his mind, he was still going for medical protocols, which might have included antibiotics. And so he had this in his head, and it's not necessarily what the DNR is specific about, right? Later on, as he approached palliative, and he was in palliative care, he withdrew all his medical medication, not just pain medication, but all medication. So to him, he didn't want any IVs or any medication at all. So it was not just heroic measures, but I don't want anything else. I've had enough. And in fact, those were his words. I've had enough. So I just wanted to point out that DNR, and you've pointed it out, it's not imminent. Death is not tomorrow. It's just, he knew the quality of his life was gone. So I just wanted to mention that. And it was, at first DNR does make you feel like, oh, he's given up, but he hadn't given up. I just wanted to point that out, that it gets registered, and you had mentioned the code number, and I'm not sure if other people picked up on that. And he kept it from his kids till the very end, until he was in hospice, and it was not even a question anymore. So that sometimes happens.
Thanks for sharing that, Eileen. Lynn, did you want to respond to?
Yeah, I want to jump in for Eileen. Do not resuscitate does not mean do not treat.
Right.
You can still take treatments, but when it comes to the point of your heart stopping, that's what you're saying no to. Do not resuscitate my heart that has stopped beating. Meanwhile, you make all your decisions about what treatment you want. And people have trouble they think if I say do not resuscitate, it means you're just going to walk away and ignore me. It does not mean that at all. No.
Thank you.
But I also needed to mention, you talked about more than one substitute decision maker. And then someone more recently mentioned substitute person 1, substitute person 2, substitute person 3. And that's a really interesting clarity. I understood it, but I'm glad it came up as something for people to understand.
Yeah, that's correct, Eileen. I think there was a time when we were, it was either one or it was 2 or 3 at the same, and we've moved towards more of this alternate, as Elaine was talking about, which seems to be, the lawyers like it much better for sure. So on that note, we're almost out of time. I want to thank everyone for participating today. It's the first time I've done a session where the numbers went up as the session went on. So I obviously this is an important topic, and the 3 of you, Ann, Elaine, and Adrienne, we could have asked for a better conversation with you. Thank you very much for sharing all your wisdom and your experiences and your stories. And I think what I want people to walk away with is what I heard was, do this early. Don't wait for a change in your health or a change in your needs to have these conversations. That's not the time to have them ahead of time. And to have the kind of conversations that will help your substitute decision maker make sure that you get the care that you want. Not what they want, but what you want. So I've got stickies everywhere on my desk right now of all of the things. Thankfully, this session is recorded and I will be sending it out to you so that you can take another look. I also want to mention that now that you've had this overview, this great deep dive, we have a conversation cafe in November where you can come and talk a little bit more about what this has meant to you and what you're starting to think about for yourself. And we also, this beautiful team of ACP ambassadors will be holding a session on the topic of how to have the conversation and what to talk about later in November. So I will send all that information out to everyone. Thanks very much. And to Elaine and Ann and Adrienne, major thanks. You did a wonderful job today. Thank you, thank you, thank you. And thanks to the ambassador team.